with respect to AL amyloid, which is probably the most common amyloid and certainly in hematology oncology practice, if one thinks about it as like multiple myeloma, but with a clone of limited replicative potential, it's not surprising that therapy over the years, going back probably to the late 70s and early 80s, have been based on therapies that have demonstrated to be effective in multiple myeloma. So the initial therapeutic trial that was done was Melphalan and Prednisone, after there had been a couple of case reports suggesting that that might be effective. Ultimately, Mayo Clinic did a study suggesting that, indicating that Melphalan and Prednisone was an effective therapy. And since then, there have been a variety of therapeutics developed for myeloma that have been adopted to the treatment of AL based on the fact that you wanted to suppress the malignant clone. And so a variety of oncologic agents were used, and as well as others. I think current therapy appears to be the most successful stage, and uses the anti-CD38 antibody that have been successful in myeloma, and couples that with a proteostasis inhibitor, either systemic or oral, and that seems to be emerging as the state of the art. The Andromeda trial in Europe is testing that hypothesis now, that this regimen will be useful and should be the standard of care at first at presentation as frontline therapy. But that has not been completely adopted yet. And there are now other antibodies that have been tested in myeloma that, if they're successful in myeloma, will probably move into the treatment of AL. The major problem with AL currently is that even though one can get a considerable proportion of complete and very good hematologic responses, organ responses tend to lag behind, particularly involvement of the heart, but also peripheral nerve and kidneys. And the notion is that these organ responses, or the organ damage, is either a function of ongoing deposition of aggregates, or the fact or the response to aggregates as tissue damage in itself, or that the tissue repair processes are just not adequate to repair the damage that's taken place. So I think that much of current work is done not only on improving the hematologic responses, but also improving the organ responses. And people are working, there has been one approach, or a couple of approaches, to mobilizing fibrils, some based on antibodies, one of which has been discontinued. Another is still in trials now and has some promise. In addition, there are approaches like using TUDCA and Doxycycline in combination, which have been shown to diminish fibrils in animal models in patients, and the use of EGCG, epigalactin, to mobilize fibrils as well. These are theoretically likely. There have been small clinical trials, and they appear to be relatively benign, but their clinical efficacy has not really been established. I think the best or the most promising of the trials thus far are those using antibodies, but it's still relatively early in the course of those studies to know what the role of those antibodies will be in the usual treatment of AL.